So what do we recommend for cardiovascular health and spinal cord injury? Well, we recommend that you pay special attention to nutrition, that we try to do pharmacologic management as possible, exercise and lifestyle management, blood pressure control, and reducing cardiometabolic risk factors. It's very similar to what we recommend in the non-spinal cord injured population, just with a few tweaks perhaps or particular things to pay attention to. So when we're talking about nutrition, as I've already mentioned, obesity is quite high in spinal cord injury, estimated at 50 to 75% in the spinal cord population. And often we see nutritional inadequacies. When there have been studies done on actual dietary intake in spinal cord injury, we often see lower protein intake than recommended and higher carbohydrate intake. And higher fat intake. So there's a shift in the calories. That may be due to the fact that it's harder for people to prepare food themselves, and they may be more reliant on pre-prepared foods or packaged foods or takeout foods. It may be due to socioeconomic factors and the fact that they may not have the financial resources because they may have altered finances following an injury to adequately source their dietary intake, but we do see nutritional inadequacies. So we recommend very similar, a heart-healthy, whatever that heart-healthy diet is, usually a Mediterranean style diet, high in fruits and vegetables, nuts, legumes, grains, lower in saturated fats. So we recommend that heart-healthy diet, but we also recommend a caloric reduction. So for patients with paraplegia, patients with lesions below T1, we recommend sort of 5 to 10% fewer calories than is usually recommended. And then in tetraplegia, it's actually 10 to 15% fewer calories. But it's really important that we're taking into account any other comorbidities that may be happening and any other nutritional deficiencies. If they have a pressure ulcer and we're trying to make sure that they've got enough protein for wound healing, we want to make sure that we're not increasing the risk of sarcopenia any further than it's already at risk. So it's trying to make sure that they really have that nutritional information and dietary information. So that's why we recommend considering referral to a dietitian or a nutritionist who has spinal cord injury expertise or expertise in working with other patient populations that have a lower activity level. So someone who's got that familiarity with those caloric needs and the special needs that we might see following spinal cord injury. In terms of pharmacologic management, there generally aren't SCI-specific recommendations for blood cholesterol or diabetes. So we usually follow any recommendations for those issues in terms of whatever our national guidelines are, whatever our Canadian guidelines are for blood cholesterol, for diabetes management, for hypertension management. We will recommend that we follow the Canadian guidelines. So you'd use the same guidelines as you'd see in non-SCI. But there are some things where we would alter things a little bit. So for example, in terms of diabetes, we generally would try to avoid the SGLT2 medications, so the flozins or the gliflozins such as Jardiance, for example. Because of the fact that there's that slightly increased risk of urinary tract infections and genital infections, we want to make sure we're not putting patients who are already at high risk of bladder infections and catheterization at increased risk. So we might not use that medication. There really isn't any evidence or studies yet in terms of the glucagon-like peptide 1 agonists following spinal cord injury. We think that they may be effective and may be something worth trying because of some of those factors that I've already talked about. The fact that there is a decreased caloric need following spinal cord injury, so they may help with that appetite suppression and reducing caloric intake. They do seem to help with improving that sense of satiety or fullness, and so again, because we see that altered sensation following spinal cord injury, we think that that may be helpful. But as I said, we haven't actually studied them in spinal cord injury yet, so we don't know any long-term effects. In terms of exercise, same thing that we would generally recommend to the general population is that exercise is important. We want to make sure that people are getting their exercise. However, following spinal cord injury, it's that much harder to get exercise. So we do have actual SCI-specific guidelines. These are guidelines that have been developed by Dr. Kathleen Martin-Guinness and her group in terms of SCI activity out of UBC Okanagan, but they are our national guidelines. And the recommendation is to try to start with aerobic activity, 20 minutes 2 times a week at moderate to vigorous intensity levels. So starting there, and then strength training activity, 3 sets of 10 reps 2 times a week. And then advancing to that aerobic activity, 30 minutes 3 times a week of moderate to vigorous intensity, and strength training staying at that 3 sets of 10 reps 2 times a week for each major muscle group that the patient can use. The challenge is that lots of times it's really hard for our patients to get that exercise. If they're using wheelchair propulsion, they're using their arms and they're trying to get that exercise, but they don't have those major muscles in their lower extremities, so it's harder to get up to those heart rates. We also may see that that change in their sympathetic nervous system, that we may not see that increase in heart rate. So we really have to try to use that heart rate reserve to try to calculate what their target heart rate is and see if we can obtain that. Other options are arm ergometry, so people can have arm ergometers, which are basically like desktop arm bicycles, or they could have hand cycles where it's an actual cycle that they go outside with an arm cycle. Swimming, sometimes some patients can use swimming. They can do circuit training, and we can do electrical stimulation. So functional electrical stimulation, which uses electrical stimulation of muscles. You can even stimulate some of the denervated muscles, and we do see some of the benefits of exercise. The challenge is that we don't have people having a lot of access to FES. Most people don't have access to functional electrical stimulation at home, and if they're trying to access it through a therapy clinic, a physiotherapy clinic or something, they don't have the resources to go frequently enough to be able to pay for that. So that's an area that I think we really need to think about advocating for this patient population is modified exercise equipment in public gyms, community centers. Can we get them that modified exercise equipment? Here in Vancouver, we're really lucky because at ICORD, International Collaboration on Repair Discoveries, the Spinal Cord Research Center at VGH, we have a gym, we have an accessible gym called PARC, P-A-R-C. So if anyone has patients living in the Lower Mainland, they can access that accessible gym